Hello, everyone. My name is Kibilery Williams, and I'm the newest member of faculty in the Department of General and Thoracic Surgery here at Children's National in Washington, D.C. Today, I'll be highlighting updates from the published literature over the last 5 years or so on the treatment of appendicitis in children, and I do hope that you'll find some of these studies helpful to your practice. I have no disclosures. So I'd like to present these articles that seek to answer clinical questions under these subheadings within the topic of pediatric appendicitis, starting with imaging modalities, looking at some aspects of management of both uncomplicated and perforated appendicitis, and then just a few highlights around operative technique, observations from the COVID-19 pandemic, and then the very distinct subpopulation of patients with cancer-related neutropenia who develop appendicitis. Although appendicitis has traditionally been a diagnosis made on the basis of characteristic features of the history and physical exam, it's become common practice to use imaging adjuncts to confirm diagnostic suspicion, particularly in children where the pathognomonic symptoms and signs may be difficult to elicit and indeed are only present in about 50%. In the US, the ultrasound has become the workhorse in this endeavor, with CT and MRI playing a role in equivocal cases. This meta-analysis of 21 studies simply adds data to what we often observe in the pediatric population, which is that there's no single history, physical exam, or lab finding, or even pediatric appendicitis score cutoff that will completely eliminate the need for confirmatory imaging. Furthermore, with the increasing popularity and discussion around the non-operative management of appendicitis, the classification of the type of appendicitis and not just the diagnosis means that our reliance on imaging will become more pervasive. Which brings us to the ultrasound, the typical first-line imaging modality in the diagnosis of appendicitis. The accuracy has improved over the years with a sensitivity of 88% and a specificity of 94% in one meta-analysis. And once the appendix is visualized, the results are almost equivalent to that obtained with a CT scan. The difficulty arises when the appendix is not visualized, and the question becomes one of second-line imaging and radiation exposure. In this institutional retrospective review from Singapore, 641 patients were admitted from the ED for abdominal pain and underwent an ultrasound, of which 160 had a non-visualized appendix. Of these, 17, or only 10%, actually had appendicitis, and in 14 of these, there were secondary signs on ultrasound, leading the authors to conclude that in patients with a non-visualized appendix on ultrasound imaging and no evidence of secondary inflammatory changes, the likelihood of appendicitis is less than 2%. When the appendix was visualized, the accuracy of the diagnosis of appendicitis was 99%. Here are those secondary signs: echogenic fat, shown in B, pockets of fluid, shown here in C, and an appendicolith in D. In the typical step-ladder approach to confirming or ruling out the diagnosis of appendicitis, an equivocal ultrasound is often followed by a CT, particularly in older children. Computed tomography has long been controversially associated with the risk of malignancy. This recent study from South Korea sheds further light on these concerns. This was a nationwide population-based cohort study using an insurance claims database of over 800,000 patients who underwent an appendectomy between 2005 and 2015. Patients with documented cancers were excluded, as were those who had cancer-predisposing syndromes, and patients were grouped as CT exposed if they had had a CT either 7 days prior to or 7 days after appendectomy. The median age was 28 years, and follow-up 8.2 years. The authors found a higher incidence of hematologic malignant neoplasms, specifically leukemia, in the CT exposed group, and this was more pronounced in the 0 to 15 or pediatric age group. The increased malignancy risk was demonstrated to begin 3 years after exposure. There was no difference in the incidence of abdominopelvic solid organ cancers. Of note, the study also demonstrated an increase in the use of CTs from 10% to 45% of the patient population during that 10-year study period. The results are somewhat limited in generalizability and may not be reflective of the true malignancy risk with the newer, lower radiation dosing protocols used in most modern CT scanners at children's hospitals. However, they do underscore the judicious use of CT scanning in the vulnerable patient population that we treat, and beg some consideration to avoid routine use, particularly after an equivocal ultrasound in a child who may be better served with observation. To summarize, imaging confirmation of the diagnosis of acute appendicitis in children is increasingly common. Ultrasound is a sensitive and specific first-line modality. Even if the appendix is not visualized on ultrasound, the absence of secondary signs confers a risk of appendicitis of less than 2%, and CT use may be associated with an increased risk of hematologic malignancy. On to uncomplicated appendicitis. The current standard of care for the management of uncomplicated appendicitis remains appendectomy. Following reported successes in the adult population, the non-operative management of uncomplicated appendicitis, that is, with solely antibiotic therapy, has come to dominate the literature over the last 5 years or so. This infographic summarizes the results of 2 of those studies. The first was a non-randomized multi-institutional prospective study conducted at 10 children's hospitals across the US, in which 370 children with imaging-confirmed uncomplicated appendicitis for less than 48 hours were given a 7-day IV then PO antibiotic regimen. Initial success was 85%, and at 1 year, 67%. Disability days were significantly less with non-operative management. The second is a single institution randomized study of non-operative management with a 10-day IV PO antibiotic regimen, in which they also found high initial success rates. But at 5 years out, 45% of the patients had undergone a subsequent appendectomy. This is an interesting and recent study from Boston Children's, looking at trends in the use of non-operative management at US hospitals, early and late treatment failures, and subsequent healthcare utilization. The investigators conducted a retrospective cohort using the FIS, which is an administrative database, across 47 US children's hospitals. They examined children less than 19 years old with a primary diagnosis of acute appendicitis during the study period of January 2011 to just before the pandemic, March 2020. The final sample comprised over 73,000 children with simple appendicitis, of whom 14% were initially managed non-operatively. The use of non-operative management was shown to have increased over the study period as seen in the graph, ultimately plateauing at about 30% after 2018. Of those managed non-operatively, cumulative failure at 5 years was about 23%. 45% of those had perforated appendicitis at the time of failure. Higher rates of subsequent ED visits, hospitalizations, imaging, and post-op complications plagued the non-op management subset. What these studies seem to all suggest is that overall, non-operative management is safe in that there are no reported adverse outcomes, and the practice of non-operative management seems to be increasing. COVID's had an effect, which I'll comment on later, but even prior to this, the trend was one of greater uptake. What seems to also be true is that there is universally high success initially, but at 5 years out, this number falls. There's also a substantial risk of recurrent appendicitis and potentially perforation and increased post-op complications, although these findings have not been demonstrated in smaller studies. Non-operative management seems to result in a longer hospital stay initially, but overall, fewer disability days than upfront appendectomy. There's still much to be understood, of course, before embarking on a paradigm shift to routine non-operative management, including the performance of larger randomized trials with long-term follow-up and a clear definition of treatment failure and also quantification of the malignancy risk, if any. Careful patient selection will be necessary with standardization of those criteria as well as the antibiotic regimen. Shared decision-making with parents and families will be paramount with full disclosure of risk, and it'll also be important to identify predictors of those patients likely to fail so that families may be counseled appropriately. With respect to antibiotic use for uncomplicated appendicitis managed with appendectomy, there has been level 1 evidence since at least 2010 to suggest that a single preoperative dose of antibiotics is sufficient for SSI prevention and that no further post-op doses are required. These studies within the last 5 years have examined what that antibiotic regimen should be at US hospitals. Cameron et al. Used the NISQIP and FIS databases to compare 30-day SSI rates among those who received piperacillin-tazobactam and those who received a narrower spectrum regimen of either cefoxitin or ceftriaxone metronidazole, and found no statistically significant differences. Cashton et al. Took it a step further and used the same two databases to demonstrate that ceftriaxone metronidazole was associated with a 90% reduction in the odds of SSI compared to cefoxitin. These data are from US children's hospitals, which may limit generalizability to an international population. However, this recent work does underscore the importance of antibiotic stewardship and standardization of care where appropriate, and the management of uncomplicated appendicitis provides an excellent opportunity for these principles to be applied. And lastly, another plug for protocol-driven care, which has been shown to optimize resource utilization and decrease variation. With respect to same-day discharge after appendectomy for non-perforated appendicitis, this was a retrospective cohort study using a national inpatient database to assess 30-day readmissions in children discharged on day of appendectomy compared to those discharged in the subsequent 2 days. The authors found no statistically significant difference in readmission rates, and this practice has been increasingly adopted at US children's hospitals. Here at DC, we're currently protocolizing discharge from the PACU or recovery area after a period of observation. Switching gears now to recent studies around perforated appendicitis. The first question, to operate or not to operate, continues to be the most difficult to answer. There's no consensus in the pediatric surgical community as to the optimal management strategy, and there are data, albeit heterogeneous, to support both approaches. These are a few meta-analyses and comparative studies from the last 5 years. In everyday clinical practice, a distinction is often made between perforated appendicitis with free fluid and perforated appendicitis with a well-defined abscess or phlegmon. When studied separately, the data from the aforementioned studies and others seem to suggest that free perforated appendicitis has better outcomes with early appendectomy, including fewer complications, fewer readmissions, shorter length of stay, and being more cost-effective, particularly if the symptoms were going on for less than a week. However, as relates to the subset with an abscess or phlegmon, they seem to do better with an initial approach of non-operative management, with fewer complications, longer length of stay, more cost-effective when symptoms have gone on for more than 7 days. However, in that initial non-op management group, of course, there is the risk of recurrent appendicitis, and those numbers vary from 15 to 34%, and brings up the discussion of the interval appendectomy. However, there really aren't any recent large randomized control trials to guide management, and so the decision remains up to surgeon discretion. Institutional protocols in this regard would help limit variation and guide further study. With the operative management of perforated appendicitis comes the risk of a post-op abscess, estimated at up to 25% in some series. As we know, these patients often linger in hospital, sometimes with fevers and overall poor clinical resolution. The question initially examined by Nielsen et al. In 2016 of when to image such patients is therefore frequently encountered. This institutional experience was re-examined using a large database, and in both cases it was shown that earlier imaging before post-op day 7 was associated with more frequent repeat imaging. And in the national database study, fewer interventions and higher readmissions, suggesting that post-op day 5 may simply be too early. Waiting until post-op day 7 seems to be more prudent, especially considering that CT was the most common imaging modality in both studies and the need for radiation stewardship, which we discussed earlier. What to do about the abscess once we've imaged it has also been the subject of recent research. There is no doubt that patients with large abscesses respond well to the combination of intravenous antibiotics and percutaneous drainage. But what size constitutes large, and will smaller abscesses do well with antibiotics alone? The first is an observational prospective study from Kansas City, in which 95% of post-appendectomy abscesses smaller than 2 centimeters were managed with antibiotics alone, with no difference in length of stay, healthcare visits, or antibiotic duration. The second is an update of the literature examining 3 studies, the first included, in which antibiotics alone successfully treated all abscesses smaller than 3 centimeters and 80% of abscesses between 3 and 6. With respect to antibiotic stewardship and perforated appendicitis, perhaps the most significant contribution to the literature in the last 5 years has been the IMPACT trial published last year. This was a multi-institutional prospective trial in children with perforated appendicitis, randomized to either monotherapy with piptazo or Zosyn, or 2-drug therapy with ceftriaxone and metronidazole. The primary outcome was 30-day post-op intra-abdominal abscess formation. 162 patients were enrolled during the study period. Compared to the ceftriaxone metronidazole group, the piptazo group had significantly lower intra-abdominal abscess rate, lower post-op CT imaging rate, and fewer ER visits. Multivariate logistic regression analysis found the use of ceftriaxone metronidazole versus piptazo to be the most significant predictor for developing an intra-abdominal abscess. They concluded that in children with perforated appendicitis, post-op monotherapy with piptazo is superior to standard 2-drug therapy with ceftriaxone metronidazole and does not increase antibiotic-related complications or antibiotic exposure duration. With respect to conduct of the appendectomy, there seems to be one question dominating the pediatric literature in the last 5 years. In patients with perforated or complicated appendicitis, and assuming a laparoscopic approach, should we be irrigating the peritoneal cavity or sticking to just suction when it comes to decreasing the rate of intra-abdominal abscess formation? These studies unanimously reported no difference in outcomes, with the Italian review even suggesting longer operative times with irrigation. However, it may boil down to what you're irrigating with. In this pilot RCT from Houston, 100 consecutive patients with perforated appendicitis between April 2016 and March 2017 were randomized to povidone iodine irrigation or no irrigation at all, and there was a trend to a lower rate of intra-abdominal abscess in the povidone iodine arm with an 89% probability of benefit. A formal trial may be underway, and certainly is food for thought. I think our experience with COVID-19 as pediatric surgeons has brought to light 2 interesting phenomena. The first is MIS-C and the fact that it can very often mimic surgical pathology, including appendicitis. As we continue to deal with COVID-19, it's important that we're aware of MIS-C in the differential of a child with abdominal pain and fever, particularly when other organ systems are involved and there's a history of SARS-CoV-2 infection. Outcomes of operating on patients with MIS-C are currently unknown. The second phenomenon is the marked rise in non-operative management of appendicitis in the presence of documented COVID-19 infection, not only in the US, but internationally. This review from Germany shows, although the numbers are small, a statistically significant increase in antibiotic-only treatment of appendicitis during the pandemic compared to prior. This recently published multi-center study confirms similar findings at 19 children's hospitals across the US, where more patients were treated non-operatively compared to before the pandemic, with no increase in the incidence of perforation. Whether the uptake in non-operative management will continue in the post-pandemic era remains to be seen. And finally, the optimal management of neutropenic appendicitis in children undergoing cancer therapy remains undefined. This is the largest study to date of children with appendicitis and neutropenia secondary to cancer therapy. 66 children with a median age of 11 were identified with neutropenic appendicitis while undergoing cancer treatment. Upfront appendectomy was performed in 41% of patients, and the remainder had initial non-operative management. Rates of abscess or perforation at diagnosis were equivalent in the groups. Of patients who had initial non-operative management, 46% underwent delayed appendectomy during the same hospitalization, either due to failure of initial non-op management or count recovery. The authors found that upfront appendectomy was associated with lower complication rates, reduced length of stay, and fewer alterations in chemotherapy regimen. Thank you so much. Appendicitis is such a massive topic and so central to what we do every day as pediatric surgeons that we can certainly go on and on. But in the interest of time, I opted to just highlight these subject areas. I'm very thankful to Dr. Petrosian for the opportunity to present to you today, and I'd love to now take any questions you may have.